You can give me a hard time about that for the rest of my life.
No, because no judgment.
No judgment. We are recording now, so
Okay.
to be official. I think so. Liddell and I today, we really wanted a chance to share some of the conversations that we've been having over the last month, and some of the things that we're hoping to touch on today that we've touched on before, I think involve four different things. One is that there are some historical and ongoing choices that we see in healthcare that really have shaped the opinions of patients, in particular Black patients. We want to talk a little bit about trust and mistrust. We want to talk a little bit about addressing the elephants in the room. I think for talking a little bit about religion and faith and sort of how that has a relationship with illness, in particular with some Black patients. Does that sound like a fair game plan, Liddell?
Yeah, it does. It does. And I think if we do as good a job as I think we're going to do, this is going to be not like the first time it's been discussed, but I think it's going to be such a monumental discussion in that it's going to cause other people to be able to have these discussions at home, in the office, in professional settings, in a car, because if we don't start having these conversations, the issues that really plague us and the foundation of it, if we want to address one of these elephants in the room, the pink one, is race.
Yeah.
And how that plays out being served to other people. When you walk in the room, nobody knows where you've been, what you know, what you've learned. They don't know you from Adam, and so, and I think that goes across the board. I don't think that's just a white, Black, thing. I think it's a Hispanic, Chinese, Indian, you know what I mean? So
yeah,
people need to try to get to a point where the credentials mean something, but I think it's the relationships that has to be built when you start talking about life and death issues with patients. And I think at many times the professionalism kind of supersedes the relationship, and therein lies what comes to mistrust by things that have happened historically and even presently in medical situations. So
well said. Yeah. So I've got two cases today.
okay.
Do you want to hear the case that we've shared before, or should I start with the one you've never heard?
The one that I've never heard.
All right, let's do that. So this is a fairly old case for me, but I was seeing a man, a Black man. We're talking about race today, in the hospital. And he was very, very sick, nearing end of life, really advanced cancer. And based on the experience and in physical exam, his healthcare team, including myself, we had a pretty good sense of where he was on his trajectory. And so we held a family meeting, and we thought we had all the key players there. we had his long time oncologist, and we had our palliative care team, and we had him and his wife. And what became immediately obvious, and I don't think I recognized it then, but I certainly do now as I reflect on it, was how much mistrust there was between his wife in particular and this oncologist. And I didn't know their past relationship to know exactly what that was based on. But what was interesting to me was how the wife was very very open about what she wanted. She spoke about how she appreciated that his professional opinion was that things were not going well, but what she really wanted was a scan to see for herself that his cancer had progressed. And what I felt was, could this be an issue of mistrust of the profession of medicine? By getting a scan, you have some objective evidence. It's not a doctor's opinion or the healthcare system's opinion. You can see for yourself that things are what they are, that it is the truth, that things are not getting better. And by getting another scan, even though it didn't matter what the scan showed, that clinically we were getting close to the end, we still got one. And it allowed, I think, this family to have what they needed and sort of accepting the situation and allowing us to move forward to talk about a plan. But without that objective piece, it felt like we weren't able to move forward.
Gotcha.
So that is one of the earlier cases that I can recall in my career where I think I started to really appreciate some of the topics of trust and mistrust. Perhaps there was a history there that led this family to feel the way that they were. I'm curious, maybe what you can identify with there, what you have seen, what your initial thoughts are.
My initial thought, just hearing that she was adamant about another scan, was that she had some medical knowledge.
Mm-hmm.
She wasn't maybe sharing that, but because what would another scan do if she didn't know how to read it?
Mm.
So that would be my initial thought.
Mm.
Secondly, more importantly, if you're going to tell me I'm going to lose my husband, which I may have been with 25, 30, 40 years, if you're going to tell me that, you need to show me why. Because I love my wife, So if you're going to tell me, 3 months, maybe she's not going to be with me, I want more than your word.
Mm.
I do. And I think even more important is, as a doctor, you should be willing to give me that.
Mm.
Because this is going past a matter of trust. This is going to a whole lifestyle change. In other words, my life is going to be changed behind this. And if that's going to be the case, then I want to know, first of all, why it's going to be changing. I know, okay, you got cancer. How come it? Because you remember we talked earlier, and one of the first things we talked about, especially about the perception of doctors, is you can fix it. You're a doctor. You can, all this medical knowledge. You guys can fix it. You're the Mr. Fix It Man.
Sure.
And so if you can't fix it, you you need to be able to tell me why. And because my life is going to change, my kids going to change, my grandkids, my income is going to change, my status. I'm going from being married to a widow. There's a lot of things that could be in that Black woman's mind, but more importantly, she's losing the love of her life. She's losing the love of her life, and that sensitivity as a doctor, RN, CNA, oncology, person, X-ray technician, especially a chaplain, that has to matter, because people's lives are going to change. His life is going to definitely change, right? And then their lives are going to change because of it. So I think the humanity has to dictate. They do need proof, and it should have been offered without them having to ask for it. That's first.
Mm.
And then secondly, more importantly, for me, there's a spiritual aspect.
Mm.
Because I'm a pastor as well as a chaplain. And my thing, just listening to the story is where was the chaplain in there or their pastor in that conversation? Because if they didn't have one, fine. But if they did, he should have been there at least, and especially if they're faithful to the congregation, and that spiritual component needed to be there, and that's why chaplains are on board in many hospitals, because you need that spiritual component. So it should have been someone else there to help balance that information. I'm thinking, but that's just me.
I'd love to know a bit more about why you feel so adamant that a chaplain or a spiritual authority should have been a part of that. That's not something I would think off the top of my head as a necessary requirement. Maybe a requirement isn't the right word, but I'm
Well, option.
Yeah.
Option. And because once again, you're talking. A couple of weeks ago, I buried my dad. During that process, the dying process, I was the chaplain in the room, but I was a son. Does that make sense?
Yeah, it does.
And so I had my brothers with me. And one of them is a minister. So we had that spiritual component to help us with this dying process. Some people don't believe in God. So the option to have had someone there to help, just to comfort, just to, support, would have been, in my professional opinion now, as a chaplain resident, would have been monumental. It would have helped, first of all, with the mistrust, I believe. It would have helped with the comfort, because I'm getting information today that is going to forever change my life. And I need someone there with me. I know there's no kids in the room. There's no, it's just these doctors telling me my husband gonna die. I might want to cry, I might, even if it's a man, where's my support? So that's just me. And not that they want a chaplain, but offering one to be in the meeting and or your own pastor, I think would have helped with that mistrust issue. Maybe not.
Yeah.
But let's be honest, most Black people have a spiritual component. So not all, but most, have a faith tradition, Baptist, Church of God in Christ, Lutheran, Catholic. And so that spirituality, especially in the dying moment, is crucial for most of us, not all.
Yeah. 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 I liked your comments about, change the words a little bit, but humanity versus what does the textbook say we should do? Just because the textbook says that, your clinical exam is enough to feel confident about whatever, being able to meet people where they're at.
Because when doctors say there's nothing else I can do, most Black people go to a higher authority. And even if the answer is no, at least they had a chance to present their case to that higher authority. And that's comforting, because we understand that sometimes the answer is no, but sometimes the answer is yes. And doctors can't explain. I don't know what happened. He just, then I watched that happen to my mother.
Yeah.
She was supposedly going to pass away within hours. And I visited her, praying all the way. Had a encounter with my Lord and Savior. And not only did she lived 4 years.
Wow.
And everything that I asked for happened. So that spiritual component is necessary. I realize not everybody will understand that, maybe, especially if they're not spiritual. You know, so some people, they'll want to find that medical reason why it turned around. But when doctors have said there's not going to be any turning around, and then there is a turnaround, I don't think you can qualify medicine as the reason it happened. I'm just saying.
Yeah.
I'm just saying. So we our faith in that context is just very important. But we all know that doctors usually are right. You know, I'd like to say 90-something%, you know, high 90s% of the time, right? You know, and so having that relationship where you trust that person who's telling you the information, and maybe you don't know them, maybe you don't have a long 20-year relationship like I had with my doctor, you know, it you know, it's different when someone stranger come into, you know, to the room and tell you, well, your husband's getting ready to die. Yeah. You're not really wanting to hear that. That's especially like, if you told my wife that, it's not gonna be good for you. Not without some scans, some charts, some graphs, you know.
Yeah.
And I assume if someone came into the room and told your wife that, it wasn't gonna be good either. Not without, you know.
You know, that's true. And
yeah,
relationships are so important.
Matters.
Yeah.
I mean, a lot. And I don't think, and let me say this, I love the fact that in that encounter that you had, you were able, and I assume you were the one who were able to convince the oncologist to get her that scan because of what you do in palliative care. And so I just want to commend you for just being in the room and giving her space to have that option. Because one of the things that people mistrust is the fact that they don't get options. And so, you know, and that, you know, this is what's going to happen, you know, that doctor, you know, no, let's give people options and let them make their own decisions about their life and their death. So.
Yeah, there's a lot that can be said about a lot of that. Like even the way that you talk about how there's nothing more that can be done. There's so many ways to reframe some of these things. There's always something that can be done. It may look different. It may not be curable anymore, but there are still ways we can take good care of you, even if that is hospice care. There's always something that we can do, and we try to offer as much as we can about what we think is going on. You need to prognosticate with some humility because doctors don't know everything. And then trying to talk about those options. What do you want to do with that time? How can we take the best care of you with that time, even if that time is short?
Yeah. And even add options that may be, what would be the term, unconventional. You know, to just make sure a patient, you know, if it's not going to go too far away, you know, to make people feel like they've been heard, feel comfortable, feel validated, and most of all, feel like you care about what's happening to them.
Yeah. You know, before we maybe transition to the other case, we touched a little bit on religion. Can I share with you a little note I made the last time we talked.
Yes.
Maybe we could talk a little bit about this. And I'm paraphrasing what I think I remember you saying. You talked, you shared an insight about something, and I never quite thought about it this way, and that is, some people out there might be disenfranchised in so many ways in life, whether it's housing, jobs, or education, etc.
Yeah, yeah, I remember that.
And it may be that faith may be one of the few things, or maybe the only thing that they really have that is theirs, they have some control over. And I think appreciating that that aspect for some of our patients, regardless of race. You may be entering into a room where they're going to talk about miracles, they're going to talk about their faith, and that may be a much bigger piece than it might be for other patients.
You know, I'm glad you brought this up, and I think you know, I've already prefaced that doctors are right most of the time. You know? And I said that because that needs to be stated. In other words, doctors don't like walking into rooms giving people "you're going to die" talks. They don't enjoy that.
No.
You know, they just don't. Even the most unfeeling, you know, most clinical, most robotic, you know, you are going to die. You know, personality. You know, no, I don't think they enjoy that, and I think people, and I'm not speaking for all Black people or anyone in general, but I'm just, when your life has been a series of not, I won't say disappointments, but disappointments maybe, where you didn't reach the goals that you had set for your life. Maybe you had some deaths that changed the trajectory of your life and how you dealt with loss of children, of parents, of your best friend, and then maybe you didn't reach that educational mark. Maybe you didn't reach that professional mark you were striving for. Maybe the entrepreneur spirit in you was great, but you never really got over the hump in that professional in that business that you were running. And so you're looking at life like, you know, I'm just never going to get over this hump, you know? And now you're faced with some terminal illness, or a person in your family is faced with that. And you have a doctor come in who you can barely understand what they're saying, or you can understand what they're saying, but maybe because of some historical stuff that you had, you know, with landlords who maybe mistreated you, you know, or a boss who, you know, set you up, you got you fired, you know, that's how you feel, you know. Historically, that's in that person's life. So they don't maybe trust white people, or they don't trust Black people, or they don't trust Mexican, you know, because they have these biases that are inside of them. And but they're religious, they have faith, right? And so for them, their faith is all they have. And because now the realization, I'm not going to be able to accomplish any of the things that I've already failed at. I'm not going to get a chance to get over that hump, you know, before I leave here, probably, you know, especially if the diagnosis was 2 months, 3 months, you know. And then the anxiety that comes with not knowledge, mistrust, and in some cases distrust happens. And I think that's why I mentioned having the clergy in the room. That's having that option. That's why when we initially opened this up, I brought that up, because for some people, that's the person that's going to help them get balance in that situation. Not all. Let's be honest. There are Black people who don't believe in God. You know, there are, you know what I mean. There are Indian. There, come on, let's be real. You know, not everybody believes.
We're all a little
and not everybody believes the same way, right?
Yeah.
But one thing we know We all believe death is coming, you know,
Yeah.
death and taxes, right?
Yeah.
And so, so, and so, having that clergy, at least having an option. In other words, before you had this conversation, would you like a chaplain in the room with you? You know, and that could cause some fear as well. Or you could give them the information, and then if they're not taking it well, then ask them, would you like a chaplain to come or your pastor to come, you know, to help you deal with this. But I'm thinking, it's just me. If that was me, I would love to have my pastor or my, you know, my friend or, you know, some spiritual presence there to help me deal with this news. I would. And I don't think I'm the only one, but I could be.
Yeah. It's prefacing or having a little pre-meeting and saying, you know, we're going to talk about some pretty serious stuff.
Mm-hmm.
What would be, who should be there so that way we can.
There you go. That's it. Yeah, that's it.
Something along that line.
Yeah, or who shouldn't be there,
or who shouldn't be there. Maybe that's a great question. I don't know that I've ever asked that question.
Who
Yeah, who shouldn't be there?
Mm-hmm.
Yeah, maybe.
I know a lot of people wouldn't want their kids there, wouldn't want their wives there. They want the information to themselves. They don't want nobody to know.
Yeah.
I have a cousin who not too long ago, you know, didn't want anybody to know. So, yeah. So, I mean, we have, and so presenting these options, and I think that's why I love palliative care. I think that's why my interest as a chaplain has continually grown in that area. It may help that my office is right next door to palliative care. but I get a chance to interact with palliative care doctors, and they say, hey, Liddell, I have a patient that I believe, you know, you would be the one that they need to talk to. And what I'm saying is that I have a palliative care team that trusts me as a resident to go and speak with people and just to be present with them, not to proselytize or, you know, try to go in there and lay hands and heal. Just go in and just be with them and let them set the tone for whatever the conversation is going to be. And but having that trust out of the palliative care team, for me, at this stage of my residency, is phenomenal, you know. And I appreciate that they trust me like that with their patients, because at the end of the day, that trust helps to build an even better relationship, not just with palliative care, but with patients. And I think patients and the families or whatever are going to say, you know, those doctors, you know, because I let them know palliative care, you know, asked me to come and visit with you. I don't act like it was something, you know what I mean, that I thought of. And so I just know faith is so important to people who have come to the end of their rope, end of their line, and all they have is hope that I'll live again, or, you know, what's going to happen to my family, or, you know, how long do I have time to get my affairs in order? There's so many questions. There's so many, and so you need someone to be with you at that moment, because I'm quite sure when you receive that kind of information, your mind spins out of control, and so that's what I'm saying. You need that spiritual calming presence with you. If the doctor can do it, fine. You know, oncologists can do that, fine. But if that's not your area of expertise, then having an option for the patient to be able to call in their own clergy and or a chaplain, in my mind, before the conversation starts, or if that's their option, is paramount to their being able to assess what they need to do next.
Yeah, I feel like I have some similar take-home points from that, even though that case was pretty old. And
Mm-hmm.
I think over the years, I've learned to be better at trying to assess what people do need
Yeah.
to make these meetings as successful as they can be.
Yeah. Yeah.
Yeah.
Because bad news is never.
Yeah.
Yeah.
All right. Well, how about let me share the first case, and then
Okay.
we've hit on a lot of the points we wanted to talk about today already. But I think this first one maybe hits a little bit on the elephant in the room. I'm going to be curious in particular what you think about, what I said and how I said it, how you think people might receive it. So the second case is I'm seeing a woman in the hospital, a Black woman. Again, we're talking about that in particular, and she was really struggling to decide if she wanted to start dialysis.
Okay.
And so palliative care was consulted to try to help her think through that, maybe be a sounding board of sorts. And the medical team was struggling with if she would even be a good candidate to start dialysis because she had been labeled as non-compliant, which, as you know, I'm not a huge fan of that term, and we've talked about why, and we can circle back to that. But as I got to know her, a lot of the themes of the narrative that she was sharing touched on mistrust. And so I tried to name at least what I thought was the elephant in the room. And once she and I had enough rapport, I asked her something along the line of, how does being a Black woman impact this decision for you? How does it impact you and your healthcare? And I really think that was an important key. And the more, and she answered the question quite frankly. And the more I got to know what she had seen and why she was thinking what she was thinking, these ideas of being non-compliant or being apprehensive about dialysis, it really all stemmed from mistrust. And she had this long history of even personally feeling that hospitals had experimented on her, fearing that they might do that again, worrying that hospitals were just gaining experience by doing these procedures.
Mm-hmm.
And we were able to eventually reach a resolution to the case. But I think the cornerstone to it was identifying why she felt the way she was, so we could at least start that difficult conversation and try to figure out a way forward.
Once again, I will not try to answer for a Black woman. Because I've learned my lesson about that over the years. I have one. So. But what I can say, even in my own healthcare, there have been times when doctors have prescribed, like I think it's a Norostatin, something like that, Crestor.
Sure. Yeah.
I've taken aspirin, for cholesterol, and I took an aspirin pill, and my doctor was a great doctor. We had a great relationship, but I took that aspirin pill from about 1995 to about 2003 or 4, and then my stomach just got really bad, and so he finally took me off of it, and then he put me on Crestor, and and no matter what dose I took, 20, 10, 5, no matter what dose I took, it felt like somebody was scrubbing the inside of my heart, for the first 25, 30 minutes after I taken, then after about an hour, that feeling would go away, right?
Mm.
So now this particular doctor passed away. I won't mention his name, but he's well known in our community. He had his own medical clinic on the north side of Milwaukee. And the doctor that took over for him, a nurse practitioner that took over for him, we developed a decent relationship over the years, right? So, he's worried because my cholesterol is about 10 points over where it needs to be. And he wants me to take this statin. I had the medications delivered yesterday, and the pharmacist called me to tell me what was coming, and he said the statin was coming. I said, no, I'm not taking that. You can cancel it, and I'll talk to my doctor, but I'm tired of, I even told him I'm tired of y'all even trying to present that to me. No matter what happens, live or die, I'm not taking any more statins. You know what I mean? And so when someone's trying to push something on you that you don't want, in other words, it's still my life. It's my choice. And I'm telling you, I'm not going to take that. And I don't want to have to keep telling you that. So, as a Black man, a little ticked off about that. And I'm just being honest, because I'm told, don't even offer that to me as an option for me to take. Cholesterol or not. If I don't get downstairs in this basement and get on this Bowflex and hit this heavy bag, get on my little bike and get this, and watch if I don't do that and I die, that's on me. But when I'm not taking it, because I know what it does on the inside. Now maybe this, and I've never taken this other new medicine. That's what the Crestor did. But the Crestor made it to a point where I don't want to know what it does. I don't care. It's not that important. I'm not gonna live forever anyway. So I think that's what's missing. That people think just you got MD behind your name and you say something's good for me. At the end of the day, I say what's good for me. And live or die. And I think that's where that patient may have been. You saying I need dialysis. So what you saying, my kidneys don't work? Well, my kidneys been working all this time. You got to give me more than I need dialysis. What does that mean for me? I got to get a fistula? Is it going to be on my neck and my arms? Okay, and if I have to get it, when does the dialysis start? And how long do I have to do it? My kidneys going to get better? So all these questions, and I know enough about these because my dad had end-stage renal disease, and so in 2007, I had to take him to have his fistula put in. He started taking dialysis in 2009. So, I'm not a doctor, but I know quite a bit about kidney disease because I had to do my homework about it. I know that most patients, depending on where I live, between 5 and 11 years on it. My dad lived about 12 years. So I'm just saying, and there may be some that live longer. I'm just saying, when you do your homework about stuff, and I did my homework on statins as well. And so when I did the homework on statins, I found that there was probably something that I could do without. And I'm just gonna have to figure out a way to get this cholesterol down other than with a statin. And there are other ways to do it. So I think, long story short, what I'm just trying to say, the mistrust, the elephant, comes from feeling like someone's forcing something on you, from previous encounters, feeling like, you don't have any other options, that you just got to take this statin. No, I'm not going to take a statin. I don't care what, you can change the name. If it's a statin, I'm not taking it.
Sure.
You see what I'm saying? So, and I'm thinking that this particular patient that you were saying was just feeling like, I don't know what else in her history, but something happened to trigger that response where I don't trust nothing y'all doing, and if we know the Tuskegee thing, we did that, we had in their personal malpractice things that happen. I got a friend who went in to a hospital to have one procedure. They end up taking out pieces of our bile and colon, which had nothing to do with why she was in the hospital for. She's dealing with a lawsuit right now. So, we know these things, being Black people. It's a Black woman, that's a Black woman. And boy, whew, her mouth is, she's a friend of mine, but I'm just saying. And so these things of mistrust are real to certain individuals. And they're real because these things have happened. And, I don't mean no harm, doctors, in trying to avoid lawsuits, will make it seem like it's your fault. So
Mm,
they have to, because there's millions of dollars involved.
mm,
And I understand that, but I'm just saying, I've been on both sides of the scenario a little bit. In other words, I was sent to a patient Wednesday before last, and this particular patient is feeling some kind of way because there are things that are supposed to be in place that isn't in place, and they're still in the hospital, not because they need to be there, but they've been discharged, but they have nowhere to go. They're homeless. So there's some family care issues, there's some social work issues, there's some things that are going on behind the scenes to get her where she can get out, but she's still a patient because the paperwork behind the scenes is not being moved along. And there's some family issues in that as well. Well, she's upset. She's speaking to staff and nurses like they're less than human because she's angry. And now she's got this mistrust, like no one cares about her. No one, wants to see her go home. And so I go up to the palliative care team, say, hey, we know that you saw before. We know she trusts you. Would you please go and speak? And so I did, and I found out what it was.
mm,
And then I went behind the scenes, talked to a social worker, talked to a palliative care team, talked to the doctor, and I found out that they're actually doing all they can, but it is family care that's holding up everything, and her own
mm,
relatives.
mm.
So when I saw her on Friday, just passed, I got a chance to share this with her, my last patient that I saw this Friday, and she was so relieved to know that she's right at the cusp. See, she thought that she was nowhere near getting there, but she's right at the door now. It's just between her family and delivering, the stuff from a medical place, to the home to help her be at home, So, but there was no communication with her, even the social worker told me, he said, I just don't want to go back down there and tell her I have nothing, because I have nothing because the people that I'm dependent on to make this move along are not getting back to me. And, I just I don't want to go out there and get cussed out. And so I'm saying that because that mistrust thing, I'm trying to get back to that. She just doesn't trust the process, and how many people, white, black, Hispanic, who don't trust the process when things aren't moving along. And I know some of it's cultural, where everybody want microwave healthcare, but that's not the case many times. And paperwork is a real part of healthcare, and sometimes it moves really slow. So communicating with people takes away some of the mistrust, is what I'm saying. And then when there's a lack of communication and it's not steady, it can cause a great big pink elephant to be in the room, and so we have to understand that as professionals, that communication with a patient is everything.
Yeah.
And breakdowns in communication can cause mistrust. And to your patient that you were talking about, I think it was once you were able to really get to her to a place of understanding what her healthcare options were, like you said, it got a chance to move on because the communication was there. But was it there prior? It don't seem like it, at least from what you're telling me.
Sure.
I think therein lies the conflict. How do we, and I'm talking about the whole healthcare team, keep communication not just alive and present, but relatable, so that people know their options.
Yeah. I like that last piece that circles back to the story with you and your doctor and your cholesterol meds. There's a difference between having a paternalistic conversation of I'm the physician, you do what I say, which doesn't work very well, as we know with our kids, versus having an actual dialogue with someone and trying. I think a lot of medical decisions, they're sort of it's a relationship. The patient and the physician each have sort of a 50-50 say in these things. The patient offers the expertise of the values, and the physician offers the expertise of the medicine, but together you really have an opportunity to have a dialogue and make decisions together, like any good relationship.
Yeah, my doctor, back in about 1995, 96, when I first met him, he said, look, Liddell, I'm your doctor. He says, but you are your best doctor. He says, and I'll prove it to you. He says, look, you came here and you told me how you felt, right? I said, yeah. He says, well, I went to school and I've learned over through classroom and clinical, and internship, how people feel when they tell me they have a certain feeling, or a stomach ache or a headache, or however they explain it. I can take what you say according to what I've learned, and I can make somewhat of an educated diagnosis of what may be happening with you. He says, but after that, that's all I can do. You know what's happening to you. And so you're the one has to tell me. He says, because I can't make a diagnosis without your information.
Mm.
And I was like, oh. He says, so you have to be involved in your own healthcare first, before me. He says, that way I can make give you the best options and even medications for your particular situation. And so that's why I'm I'm always involved in what's happening. No doctor's just going to tell me so and so. It's not going to happen. But what you can do is listen to me and take that expertise that you have from all that years of study and try to help me figure out the best options for me. Because at the end of the day, I'm really the doctor, because I'm the one that knows what's wrong. But I didn't understand that until it was explained to me by another doctor.
Yeah. That doc really must have had an impression on you. I'm going to say that might be the third time we've chatted about him. And that's really telling, that how important it was to have that dialogue, to listen to you, to meet you with where you are at.
But it made me trust him.
And trust, yeah.
I trust him.
Yeah.
He's good and gone now, but I trusted him because he wouldn't lie to me. He told me, he gave it to me straight.
Yeah. And I think most docs probably wouldn't lie to their patients, but we've got to earn that trust first before people will appreciate that that's where we're coming from.
And the second part of that is that he earned it. I saw him a few times. It wasn't like that was the first time we met and he said that. You know what I mean?
Sure.
So and then the second part of that. What? Oh, okay, good. I don't know what happened. But the second part of that is as we developed that relationship, he trusted me to tell him the truth as well. I didn't lie to him about things that were happening with me. Some people will come into a doctor's office and don't tell them the whole truth because they're embarrassed or don't trust. So it's a two-way street.
Yeah.
And getting people to be honest with their doctor, because it's a well-known thing. People will lie to their doctors and their lawyers, the two people that they should never lie to, right? They'll go. You should never. Those are two people you never lie to, but they'll go right in there. And, they're gonna pull one over. Because you do have abusers of drugs. Abusers of drugs. And they want the pills, and so they'll go in there.
Oh, yeah.
Yeah. Yeah. So I mean, this is part of the, like you said, that healthcare thing that was, that's out there. Mistrust and all of that stuff stems from that. And because you have doctors who are ethical when you look at the shingles, but they may not be as ethical when they're behind the door. You know what I mean? And when we know that because they've been busted, right? And so we have to understand that the same way we have patients the same way. They'll go in there, lie to their doctor to just try to get oxycodone or whatever it is that puts them where they want to be. And so doctors don't trust patients, because of that. So I mean, it's a matter of trust. I mean, no matter how we see this, Martin, it is trust. And that's the elephant in the room that we have to deal with. And there's so many different types of scenarios that we can't cover definitely in an hour, but we have to just have this conversation. So first of all, hopefully the people, first of all, will stop lying to their doctors when they go in. Let's just be honest. And doctors will make those people a part of their treatment, give them options instead of, you need to just do this and you need to do that. And
yeah. A lot to digest.
Yeah, well, I just believe that as a Black man, now on the inside of a healthcare giant, like AAH, I realized, and I told that patient on Friday, your palliative care doctors care about you because they don't really, I looked in the chart, they don't even see her anymore, but they had heard about her behavior in the hospital. So they asked me to go and see her. They didn't have to. They care about her. They wanted the best for her, you know what I mean? And I think that's the real thing that has not been shared with people as well. Okay, maybe not every doctor feels like that, but there are some doctors who actually care about their patients post seeing them. And that needs to be out there as well.
Yeah, boy. Whoa, yeah, that's a huge topic too. I mean, I feel like you and I could probably talk about that forever, right? I even wonder, and we won't go too far down this rabbit hole, but is the modern healthcare, the way it's set up, allow physicians to show the humanity that's really there? If you have a finite amount of time, sometimes it's tough to build those relationships to show how much you really do care. Anyways, another conversation.
And there's a build and a bill. And so it became BILL. I couldn't help it. I had to.
We should probably wrap this thing up. We're starting to go off the rails now.
Okay, come on.
I wanted to say that, Liddell, first of all, I appreciate how much you've been trusting me as a colleague, and that we're able to talk about these things. It's not easy stuff. And I'm glad that we've been speaking about them over the last few months, and that we're trying to record a little bit of this for other people to hear some of these thoughts and maybe start some of their own conversations with some of their colleagues as well.
Yeah, and I appreciate you for allowing it, because as a Black man in healthcare now, as a professional, learning to be a professional, it's important to me that when I step into a patient's room, that first of all, I'm present with them. For me, that's everything. But beyond that, that I hear them and that I give them room and space to know that they're still in charge of the room when I'm in there. I hope that makes sense. And I'm just there to help them work through things that they need to do for themselves, decisions that they have to do for themselves, or their family members, or whoever's in the room. And that when I leave the room, my spirit and my faith and all of those things didn't infect them in any kind of way, except to give them hope that they can make the best decisions that they possibly can about their own healthcare. That's what I'm trying to learn, is not to do any harm from a spiritual perspective, because we go in as spiritual care. And we need to understand, and it took me a while to get what spiritual care actually meant in turn, because I'm a pastor outside of AAH, and what spiritual care is outside is not the same necessarily inside AAH. Some differences, and I struggled with that, being honest. Struggled with that until maybe a month ago, but I'm getting it now, and I understand patients need time to consider. They need love and compassion. And I said it, love and compassion, not just compassion. They need love and compassion. They need to know you care for them so that they can trust you to tell you things that they may not tell anybody else. And then they need ethical and spirit-fed information back that they can use to help themselves to make the best decisions that they can. Now, that's just my personal opinion. Yeah, and I know the word love probably in a hospital setting shouldn't be used, but once again, I'm a pastor as well.
I think love is fair game.
Okay. I'm just saying, we want to keep this professional, but yeah, they need love and compassion. Yeah.
All right. Well said.
Amen.
I hope you have a beautiful rest of your Sunday, my friend.
Yeah, me too. And thank you for this opportunity. Appreciate it. Hope we can do it again soon. And I'm just praying for you and your family. That everything, especially right now with everything that's going on in this 44 below weather with 24, wherever the wind chill is, you don't have to go out and all that good stuff. But hopefully I'll see you soon, my friend.
Sounds good. Thank you, Liddell.
Blessing.
Bless you too.
All right.
See you later.
See you later.
Bye.